I am the Chief Officer for Pensioning and Place in the Clifton ICB and the outgoing Deputy Chief Executive of Dorset.
I'm Ms. Bidsell, I'm the Head of Corporate Governance with NHS Dorset.
Louise Trent, I'm taking the lead.
Siobhan Harrington, Chief Executive at University Hospitals Dorset.
Hello, I'm Jordan. I'm the Joint Chief Nursing Officer at Dorset Healthcare and Dorset County, and I'm here today on behalf of Matthew Bryant. I'm the Deputy.
Adrian White, Non-Executive Member, NHS Dorset.
Jane Ellis, Chief of Staff, NHS Dorset.
I'm Craig, Director of Dorset Council.
Kate Taylor, NEM, ICB Dorset.
I'll hear Non-Executive Member of Dorset as well.
Back from your marathon in Tokyo.
Yes, I need somebody sat next to me because the jet lag is going to kick in. So please, somebody hit me.
If you fall asleep and we see you doing that, we'll give you a nudge.
Hello everyone, I'm Helen Crook. I'm a Programme Manager in the Transformation team at NHS Dorset, here as part of the Women's Health team.
Sorry, I'm the Chair of Dorset Women's CIC, so I'm also here as part of the Women's Health team.
Hi, I'm Leah Gallen. I'm an Associate Director at Health Innovation Wessex, and I'm also here as part of the presentation this morning.
Hello, I'm Dean Spencer. I'm the outgoing Chief Operating Officer for NHS Dorset and the Place Director for Dorset in the cluster.
Sam Mosley, Non-Exec. Good morning, Barry Marden, Chief Medical Officer in the cluster.
Gavin Bolwood, Non-Executive Member, Dorset. And Sheila Meldrum, Chief Nursing Officer for the cluster.
McLean, Director of System Coordinating at NHS England.
Good morning, I'm the outgoing Chief Finance Officer for Dorset ICB and the Cluster Chief Officer for Strategic Finance and Resources.
Hello everybody, Jonathan Hickman, Chief Executive for the ICB cluster.
And online, Paula and Louise.
Hi, I'm Paula Bennett. I'm the Programme Director for the Dorset VCSA, which is the Voluntary and Community Sector Assembly.
Good morning, I'm Louise Bay. I'm the Manager at Healthwatch Dorset.
And Amanda.
Morning everyone, I'm Amanda Webb, Chief Officer for Population Health Improvement for the cluster.
Thank you very much. And one more there. It's Forbes. Yeah, hi Forbes.
Yeah, good morning, Forbes Watson, GP Chair of Dorset General Practice Alliance. Sorry, I can't be with you in person.
That's all right. And would you like to say hello?
I'm a Programme Manager. My name's Nikki Smith and I'm from Health Innovation Wessex and I'm with the Women's Health crew. So lovely to be here.
My name's Carl Woodruff. I'm the head of the commercial team at Synapsis. We support BSW, Somerset, Gloucestershire ICBs with referral management and urgent care flow. So I'm here just as an observer today.
Very well. You're very welcome. Do we have any apologies, please?
We've got Lucy Baker, Place Director, Bath and North East Somerset, Matthew Bryant from DHC, and Dawn Dawson is here as a nominated deputy, Rob Carroll from BCP Council, Aidan Dunn, Millie Earl, Dawn Harvey, Caroline Holmes, Catherine Howe, Nick Island, David McClay, Gordon Mavuti, Rachel Pearce, and Hester attending, and Andrew Rosser from SWAS.
Thank you very much for doing that. Are there any declarations of interest, please? Anything that's arisen in the last 28 days that isn't already scheduled? Okay, thank you very much. We have the minutes of the meeting held on the 15th of January. Are we happy? Those, please, thank you. And are we happy with the action log? Is there anything that anybody wanted to highlight? Okay, so we move to the first standing item. We have a board story on women's health. Good morning, and we look forward to hearing from you.
Very much. Hello everyone, thank you for having us here today. We are three parts of the Dorset Women's Health team, and it's a pleasure to be here to talk to you about the programme and all of the partnership working as well. We've introed already, but just a tiny bit about me. So as well as being a programme manager in the transformation team, I was allocated very luckily to this programme over about 2 years and got to work with these amazing people and many other partners. Just some quick slides for me just to set the context of the programme for anyone that's less familiar with it before I hand over the bulk with my colleagues here. So the first thing to mention is not only was this a user-led programme, you'll hear much more about this in a second. I think one of the keys to the success of the programme has been the partnership working that we've done. So we engage with all of our partners, some bottom right there from the earliest stage, and I think that's been one of the real keys, I think, to this. Next slide, please. And then nationally, we had from our Department of Health and Social Care colleagues, the Women's Health Strategy for England was published, and that's been refreshed and out later this month. They then published the Women's Health Hub core spec, and we had an amount of non-recurrent funding, and that was the same for all ICBs across England at the time. And just a note you can see at the bottom there, you may have heard that some systems around the country did put in place a physical Women's Health Hub or a clinic. The reason we didn't endorse it and some others didn't as well is because the women of Dorset, through all of our partnership engagement work, consistently and overwhelmingly asked us not to. So they said if we put one in Bournemouth, shall we say, even with non-recurrent funding, that's fantastic for people that live in Bournemouth or around, not quite as helpful for women that might live an hour and a half away at best, even if they drive. So women consistently in all of our engagement said, please bring care closer to home, please help us to navigate the system, give us evidence-based self-help and early help to make us or empower us to have our own decisions about our physical, mental health. And if you can, please skill up and provide more guidance to clinicians that we see to help us at the earliest stage. And of course, we listen to women and girls of Dorset. And we, of course, sense checked that with NHS England colleagues before we went into delivery as well. Next slide, please. So our programme vision here, so to improve the health outcomes and experience for the women in Dorset with equal and timely access to existing services. Next slide. Thanks, Jane. So from all of our engagement, all of our mapping, everything we did before we went into delivery, we had 6 key areas for change or 6 projects within our programme. So those are the Dorset Women's Health online resource or our website that Marianne will talk about extensively in a second, long-acting reversible contraception or LARC, young women's mental and physical health, menopause and perimenopause, of course, minority groups and mobile support, and pelvic floor disorders. Next slide, please, Jane. And the last one from me, I told you I'd be very brief. So just to return on investment, obviously public money, and we want to be very clear on what we've done with that. So being able to listen to our population and really understand what they need from us. And that's women and girls, of course, but also managers, the public, clinicians that work with women, of course. So as well as the work we've done with Marianne and Dorset Women, we put out a survey pre and post delivery to really complement that, to understand what women actually want with the resource we have. To complement that, understanding that not everyone will fill out a survey or hear about it or want to or be able to, we actually physically went out to different groups of women in Dorset. So different groups, just a couple to mention, were homelessness people and young women with mental health difficulties as well. We were able to get some more funding for research. Not sure if people are aware, but only about 1% of healthcare funding goes on to women's health. And even if you bring that up to include cancer, that's only 5% of the health budget. So very, very tiny. So any money we can get for more research is very welcome. I think the training we've been able to give clinicians, particularly in the space of menopause and 351 hours there, has been key. We've got menopause webinars that are now uploaded to our GP Alliance website. So thank you so much to our colleagues there who've been amazing and very helpful. And I think the last 2 things to mention are just about evaluation. So we've got a programme level evaluation. We have an evaluation of our pelvic health pathway. And we have an impact report from all of the 6 projects that Leah will talk about in just a few seconds. So that's all you need from me at the moment. Thank you so much. And I'll hand to Marianne.
Thank you, Helen. So thank you for having me. I feel very privileged to be here today. Some of you may have come across me in other roles. The Dorset Women CIC has been around now for about 5 years. And we created ourselves after we brought together 60 women leaders from across the county in all sorts of walks of life, from health and business, sport, leisure, and we created this thing called the Dorset Women's Charter, which is the QR code there is to that if you're interested in the Charter. Charter sets out 10 standards that women should be able to expect in their lives. And because women were so passionate about health, we've actually allocated 2 standards to women's health. One is around health, mental health and menopause. The second is about reproductive health, pregnancy and baby loss. So it's all in the Charter if you'd like to read it. And next slide, please. So I'm going to talk about the Women's Health online resource as one of the 6 work streams that Helen has told you about, because I really want to help you to understand the extent to which this has been patient-led. Now, I don't like calling myself a patient, and most of the women that we've worked with wouldn't either, but I'm using that word for your benefit because I know that's the word you like to use. So if you could just go to the next slide, please. This is a little snapshot of the website. Have any of you seen it? It's fantastic. It's been absolutely co-produced from grassroots up to being live online right now, and it covers 12 different areas of women's health, and that's just a little image of the homepage and the QR code again if you want to find it there. So this journey, so next slide please. Sorry. I assume you can read my mind, Jane. So this journey started for us back in 2021 when we first set up Dorset Women CIC. We set out asking women 3 questions. Tell us 3 things that you want to see change, and over and above everything else that women told us were issues around their health. And this is just a little smattering taster of what women were saying to us. I'm not going to read it all out to you, but there was a lot of repeated messages about how they wanted to see waiting times reduced, how they wanted to see consistency around interventions for menopause, things like that. They wanted to see diagnostic times for PCOS and endometriosis brought down, which are higher than the average national averages in this county. And that women out there not very happy about that. So they told us that back in 2021. Next slide, please. We did a lot of social media campaigning around this issue. We really got into it with women and got them to tell us, what is it you want us to do? What do you want us to say? What do you want us to do? Tell us in detail what's on your mind. Next slide. And so we took this out and about around the county, all sorts of different events. We held workshops, we held seminars, we went to university, we talked to students, we talked to women everywhere and said, tell us what we need to hear. And it was just a fantastic experience. Somewhat alarming at times, but amazing to go out there and speak to so many people. Next slide. And then, so that's just a little snapshot from the online surveying we did, and how, just to really labour the point that we really knew what women wanted by the time we got to the point of working with you at the NHS. Next slide, please. We held a women's health symposium in October 2022 because we'd heard so much that alarmed us that we were like, we've got to get people together and talk about this. This is just not good enough. And I have to say, at this point, we had approached NHS Dorset and had been very politely told that they were doing gender neutral commissioning and that if we wanted to work on women's health, we were by ourselves. So we thought, okay, we will. So we held a women's health symposium, and our friends from Healthwatch and the university helped us with that. And it was a fantastic event and really engaging, and some brilliant speakers from some of your amazing clinicians. But we did leave that event thinking, okay, this is possibly worse than we thought. So we were not going to let this go. And my colleagues here will vouch for the fact that I don't let things go, do I? And so next slide, please. We then decided to bring stakeholders together. And this is, I'm very pleased to say, when our NHS colleagues then came to the table, and we held 3 of these stakeholder workshops. And they're incredibly well attended, and we did some really good work about feeding back what women had told us and engaging with people from all over the NHS about how they can help. And it was a room full of such passionate people who were really committed to wanting to get stuff changed, because they knew that there was stuff that needed to be done just as much as we did by then. So next slide, please. So through those workshops, we came up with these 5 priorities, and it is this that has underpinned all of our work that we've been doing. This is what women told us. We had to tackle inequalities around women's health. We had to provide some level of education and self-advocacy, self-education around women's health so that women could manage their own health. What they were telling us consistently was that they wanted the power back to themselves, so they knew how to manage their own bodies. They already knew their own bodies, but they didn't want all the power to sit with clinicians. And that was a really strong message, which goes together with the third one, which is around prevention. Women do not want to wait until they're horribly ill to be in hospital and clogging up beds. They want to be able to manage their health before anything gets that bad. The joined up care thing is around being passed from pillar to post. You know, I won't give you an intimate, detailed account of a recent experience I had, but there are certain procedures that women have to have where maybe 1 or 2 things could be done at the same time, or a conversation could be had about something else without being passed off to someone else or then put on a waiting list for somewhere else where you're find yourself in the same kind of physical position that you were 3 months ago, where you could have had that done at the same time. And mental health was a big one for women, because we don't often talk about women's mental health, specifically hormone-related women's mental health, and women really seeing a gap in service provision around that. There's a lot of generic mental health services, really seen that improve over the last 10 years, but around women's mental health in particular, conditions that only affect women, we just not seeing enough support around. So that is how we reached our 5 priorities. And how we ended up with these 6 work streams, which Helen has talked about. So we'll skip on past that one. We've seen that one already. So in terms of building the website, I just wanted to really show you the process so that you understood how co-designed this was with women. We started with a subject, we collected Dorset data, we held focus groups with clinicians and users so that we understood exactly what it was that women wanted to see on this website. And they were very clear that one that they wanted to see was, what's normal, what's abnormal, where do I go? So we built the whole website around those 3 principles. What is normal about periods? What is abnormal about periods? Where do I go when I'm worried? And we've got 12 different subjects that is laid out in that way. We drafted first draft content. We had to have it reviewed by clinicians. We had to have whole things signed off by clinical people. So this is not just a bunch of women saying, oh, I heard this on the internet. This is very evidence-based. This is very clinically sound. And it's now up and running, and we're extremely proud of it. I think that's the last slide. Is there one more? Oh, probably just, we've seen this one already. So just that there is one more that, so next slide. That's really just to make the point that it is an ongoing process. This isn't a done deal. We are constantly still working and talking to women to keep this up to date, because things change all the time, as you know. And then the last slide, I'm sure this is the last, so just to mention that as part of the evaluation, we've also been doing a podcast. And the women that we spoke to said, we're never going to read a report. You can write a report we like, we're not going to read it, we don't care. Give us a podcast we want to hear. So what we've done is interviewed the key people that were involved in the programme and asked them to talk about what it was like, because I felt that it was so important that women really understood what goes on behind the scenes, people working so hard to improve things. And they've given us such a lot of input. We had to give them something back to say, you told us this is what these people have been doing on your behalf. And it is a fantastic listen. It's a real eye-opener. It's been really well received. I think the first 4 or 5 episodes are out now, so please do tune in and have a listen. It's quite insightful. I think that's me.
Next slide, please. So my name's Leah from Health Innovation Wessex. So we were one of the partners with all of the partners across the system that I think pretty much have included everybody here. So there's going to be somebody from within your organisation who was part of this work. And our role in Health Innovation Wessex was to really bring that innovation aspect to say innovation is going to be key here. We've got a non-recurring budget. We need to do something differently. We've got overwhelming feedback around what the women and girls of Dorset are looking to see. How do we do that? How do we do something differently? And what does that look like from an innovation point of view? Our role was also, as well as being part of the partnership and being part of the delivery of work, was also to bring the evaluation element and say, look, okay, we're going to do this. We've set out to achieve these things. What do we actually achieve? And what's the insights and value to that? And then NHS Dorset commissioned us to come back a year later and look at the impacts, which we don't often do in programmes. How often do we go back and go, has it really achieved what we thought? And what's the impact's been? And that's what I just want to take you through now, just a couple of those slides. There is a full report, an impact report that's been done. It's got so much depth into that report and into what's been done across all of those 6 projects, but just some snippets today. So, you know, large scale educational impacts, expanded the digital support, enhanced clinical pathways, and really improve the visibility of women's health needs. Next slide, please, Jane. So I'm not going to go through these in depth, but these have been taken from the impact report. And I just want to pull out a few highlights, really. So things like improving access. So thinking about new pathways of care. So actually women have said we want care closer to home. We don't necessarily want to go to the acute provider where we don't need to, where we don't need that specialist input. So what is it that we can take out of those acute providers and put appropriately with training and support into the community? So looking at new pathways around pelvic health and LARC, so long-acting reversible contraceptive, were the 2 as part of this piece of work. And also saying to women, do you know what, there's other ways you can access healthcare. There is great digital technology for those who want to engage digitally, and it should not be the only offering, but those who want to, there is great digital technology out there. So actually funding some licenses for something called a Squeezy app, which is around pelvic health. And actually supporting women with pelvic health, with exercises, with guidance, and then actually saying, actually, as part of the pathway, if that's not enough for you, or if that's not resolving your symptoms, then here's where you then go. Because the amount of women out there who just cope with the symptoms they've got and think it's normal. So actually access is a big thing. Increasing knowledge, clinician knowledge and confidence. So we've touched on that a little bit already, but I think my key point there is this is not aimed at GPs. This is aimed at healthcare professionals in the broadest terms. There are nurses out there in sexual health doing vaginal examinations who can look for pelvic floor dysfunction at the same time and appropriately refer on. There are great nurses and other professionals in GP practices providing menopause support already. Why are we not utilising the workforce as a whole rather than focusing on one key group? So that was the focus of the training and the clinician support. Measuring influence on referrals, so really thinking about, particularly in the menopause, some of the work that Tim Hilliard's done at UHD, looking at, actually they don't necessarily need to come to my specialist menopause clinic. How can I upskill? How can I give advice and guidance? How can we do things differently so that actually the right ones come into that clinic and the others get the support in a different way? Next slide, please. Again, strengthening our community engagement and support. I think Marianne has spoken to that, but just some numbers to think. At the time of writing this, so this is a few months old, it was 28,000 views over. This is going to be even more now. That's how many people are accessing the website that you've heard about to get online information and support and signposting, let alone the access to the podcast and let alone the other engagement work that's been done. And it is ongoing. That's the key thing. Driving innovation and driving the reach. I've talked a little bit about some of the digital apps. I've talked a little bit about the Squeezy app, but there's lots there now, and that's not changing. So thinking about sustainability, we've put in place some things through this programme that will continue. So sustainability was a key thing we talked about right at the beginning to say, the programme's limited, the funding's limited, but can we create things that will be ongoing? Because that's key at the moment. Understanding the barriers and experiences, again, I think we've talked about that and how we did that, but I'd also pick up that we actually looked at schools as well. So vaccination program within schools, the HPV, other ways actually, thinking about those girls, what's normal with periods, the vaccines, what else can we do at school age and not just targeting adults? Next slide, please. System-wide collaboration and national influence. So that's a key thing that I want to pick up, is that we were fortunate enough to present at NHS Confed last year. Through the work that we've been doing, both as a system, but also within the Health Innovation Network, we have influence nationally from the work that Dorset's been doing. So, for example, accelerating innovation systems with the Health Foundation. Dorset is in there as a case study around women's health. Around the national strategy that you've heard is going to be published. There's a refresh coming out on the 18th of March. Health Innovation Networks and some of the work that we've done, and an example from Dorset we're hoping will make the final cut. So we're influencing, and we've shared a lot of the work that we've done with NHS England, with NICE colleagues. They're looking at what we're doing, and they're looking at how can that align to the NICE process around EVA, or the NICE process around what's approved from an innovation perspective, or what priorities are NHS England looking at that can then be informed from what we've done in Dorset as well. Improve capacity for women's health, so the training and then the data and evaluation. That was a key part to really make sure that we're looking at what we set out to do and have we achieved that, and what does that really mean for Dorset? What's the benefit that that's brought to Dorset? Next slide, please. So what are the potential gains? So just a little bit to touch on data. There is an awful lot, and we need to remember that actually a lot of the workforce in the NHS are women. So actually we're benefiting our own workforce through this work. And actually you can see there how many sick days are lost with women's health related issues. So this is actually about keeping our own workforce at work as well as supporting our population as well. Next slide, please. So my final slide is just around what's happening regionally and nationally. So I've mentioned the strategy that's now coming out on the 18th of March. There is also work happening around neighbourhood working for women's health. And there is a workshop happening on the 30th of April across the entire Southwest. that will be focused on women's health. So it's being led by the Health Innovation Network and NHS regional teams, and it will be looking at what are the priorities specifically for the South West, so specifically for Dorset, the new cluster, and what does that look like moving forward, particularly taking it into that neighbourhood model. Thinking about the equity framework, I've mentioned NICE and the work we're doing. The other thing to note is that we have got a Health Innovation Network cluster programme starting in April. So that's supporting the regional workshops, but I then will be designing a national programme across all the Health Innovation Network for women's health over the next 3 years. So we have influence, because I'm the lead HIN, to actually write in what that is from the work we've done in Dorset and really influence that. That will be focused around innovation adoption and how that looks within pathways. So really thinking about the wider services and pathways, not just a nice shiny digital thing. Thinking about what that looks like and how that can bring the most impact and really help the local needs and regional needs. Over to questions.
Great. Thank you very much, Helen, Leah, Marianne. That was really interesting. Thank you. Any questions or comments? Bernie?
Thank you. That was, yeah, brilliant. Really good example when you really take the time to understand need, where it takes you. I suppose one of the things that strikes me is if we can't get women's health right for women, what hope have we got of getting health right for women? Because the other thing in play is the history of, there's a lot of history to unpick, because if you look at things like research is very biased towards cohorts of largely white men, drug development, dose finding, a lot of the published dosing regimes are usually based on biological entity that is a man. Guidelines, how women are much more at risk of having a late diagnosis of heart attacks, for the difference in how they present and how we're continuing to train people into a particular paradigm. So I'm interested in what it is that we could learn from the approach that you've taken when you're looking at things that are specific to women in terms of their health and meet their needs, how we take that to look more generally about how we meet the needs of women within health.
Happy to take that first. So Bernie, absolutely right. So a couple of things. One, Wessex Health Partners across Wessex have created a research network for women and girls. And part of the work that they did alongside this programme was to pull what research is happening. Because you're absolutely right, it's not there in a lot of areas in the infancy. And actually that's an area we need to start, and that's not going to happen anytime soon. That's going to be quite a few years in the process of looking at the research and actually getting some of that underpinning information. The second point I'd make is you're absolutely right around the alignment with other conditions. So cardiovascular disease comes up quite regularly, osteoporosis. There's a number of key conditions where women will present differently. And actually we need to start thinking about that within those wider programmes and how we're addressing that, rather than singling it out, say women's health CBD. Actually we go CBD, where's the women's aspect in that, and what does that look like, and how do we train people to spot that differently? Anyone want to say anything more?
So to say the report that Leah just mentioned, we can share the link. So that's the Wessex Health Partners report. I'll share it with colleagues so that can be sent to the board as well. I think it's something we're trying to, Marianne mentioned earlier about the website and continually updating it based on the feedback that we get. We have had feedback from women themselves to that, to say, website looks great, thank you, but what about fibromyalgia or heart attacks or other things? We started with a set scope for the website, which was really what women asked for, of course, through the engagement, but also through the Women's Health Strategy for England that we've mentioned. But we're aware that women want to know more about those things to help empower them to make those decisions. So that's something that Dorset Women are looking at when we do updates to the website, which is quite regularly, to signpost to information for women on other conditions that affect them differently. So that's just something to mention as well.
That's what I would add, Bernie, is that the women can tell the difference between a tick box exercise and proper engagement. And I think what this project has shown is that women and the public engage very differently when they properly believe you're listening to them, and they have a real influence over the outcome. They can tell, I won't say we, they can tell, and they tell us they can tell And it's a waste of their time. They're too busy. Women are busy. They haven't got time to fill in a questionnaire for your benefit, but they will if they think that they have an influence.
Rhiannon, and then Dan, and then Sheila, and then Siobhan. I'll take you all together.
Thank you. It sort of builds on, so I want to say we were lucky enough to have a presentation in the Quality and Commissioning Committee. So huge supporter of the bottom-up approach that this has taken. Sort of slightly builds on what Bernie was asking, but probably it's more in the engagement space. So I totally can see that there's been massive engagement. The bit that isn't clear and doesn't come through is the group, you know, it's an older population in Dorset, potential digital exclusion, and a lot of the approaches have been through that. So picking up, you know, aging well, risk of osteoporosis and other things. It's that engagement piece for that cohort of the population that we don't leave them behind and create an inequality through a sort of age lens. So I just wondered, we talked about it and it wasn't quite there yet, possibly, and the ask was that that's considered in any kind of work that the cluster might take forward from the great work, and it is great work. So please don't.
I'll take a few comments if that's all right, and then come back on them together. Dan, and then Sheila, and then Siobhan.
Thank you, and thanks especially for including the ROI stuff in there, because quite often these presentations don't. That then triggered a question, and I sort of should declare I'm an accountant rather than a clinician. But my question is coming from a kind of how can we help you prove the value, because we want these things to carry on, particularly with kind of with a commissioning hat on. It struck me a lot of the ROI impact stuff was output rather than outcome. And I know part of the answer is outcome is both hard to measure and it's long term. But how can we help you demonstrate those outcomes? Because then it just closes that commissioning loop that we have to carry on. And so I just wondered if you have any thoughts on outcomes alongside outputs in evaluating performance.
It's going to be a memory test for you this week. Sheila, and then Siobhan.
Thank you, and thank you for the presentation. Amazing work. I just the detail may be in there, but I was just wondering about the engagement with girls and young women, and how that spread, because they would have they'd have different views, wouldn't they? And you might think, well, you know, mums can represent youngsters. If I tried to represent my 20-year-old, she'd be outraged. So just a little bit of info about was that engagement.
Thank you. Finally, Siobhan.
Just a belated Happy International Women's Day to everyone. I was really struck by a statistic at the beginning that I think you said, Marianne, about the 1% and 5% of health services. That's pretty shocking, isn't it? And I've been blown away by what you've described. I think it's absolutely excellent. You've created a movement, you know, that's what I
That's how we describe it, actually.
And that to me just seems there's a lot of learning here that we really need to think about and consider. I suppose what's interesting is I have heard about it through some of my clinicians and they are enthusiastic about it, which is really great. And also gynecology, over the last year, we've gone from absolutely having a horrendous waiting time. Yes, there's a lot of variables and we've done a lot of work internally, but actually it's quite interesting. I don't know how much of an impact your work has had on the fact that actually it's in a much better place than it was. And that's, I suppose, one of my questions is how do we look at that? Because that would be interesting. And then secondly, will you come and talk in the hospital for me? Because that would be great.
So several questions there. Learning, ROI, engagement. Over to you.
Can I go first? Go for it. I suppose just responding initially to Siobhan, because I'm obviously menopausal and don't remember a great deal. Answer with what I can remember. You know, one thing about creating a movement, Siobhan, is that unfortunately we're going nowhere now. We started at a momentum, so we have a lot of women who are now very engaged with this work and want to see what happens next. So that also kind of answers your question about outcomes. Keep asking women, because they will tell you. They'll tell you if they're not happy, but they'll also tell you if they are happy and that, you know, they're engaging with the podcast. You can tell that people are really interested in this subject. You know, women can't talk enough about it. So I would say, or wouldn't I, that, you know, to measure outcomes, because the other thing I would say is you've heard about it from your clinicians, and I think our Health Symposium, there are a lot of clinicians there, and you just don't know what the impact we've had just having the conversation publicly that isn't actually even just part of the programme. I know that Daniel, for example, went off furious, and so probably things happened just because we talked about it in public. And a woman stood up in the audience and held him to account at that symposium, and it was embarrassing, but it was fantastic, and he was brilliant, and I know the two of them continue to speak. And so that's how you measure outcomes, is keep talking to women about, are we there yet? Are we good enough yet? What next? Has this worked? And then there was something else I was going to say, but it's gone.
Should I go through the names?
Menopause and
I wrote
action.
it. I'll write it down. I'll add just something to that. Thank you. So I think in terms of those measurable outcomes, I think it's a really good point. To some extent, we may not know until further on, which I know is a frustrating thing to say, but literally, you know, the website, has that reduced the amount of women who need to go and see their GP or another healthcare professional? We're too early to measure that yet, but in the future we might be able to, and I think it's important to get that feedback. Another thing I want to mention, though, is about the sustainability of this for the future. Yes, we had non-recurrent funding. Yes, it was a programme, and the nature of any project or programme is that it's time limited. It's a temporary structure. What happens afterwards? So sustainability wise, we do have a lot of our brilliant partners, a lot of them that you work with, who are taking forward some of this work still. But I think an important discussion, something on all of our minds, is what happens with the new cluster. And I've spoken quite recently to my counterparts in Somerset and BSW, who are equally as passionate about this. We're all at different stages of what we've done. But as Leah set out, there will be more national mandates and national asks about what is happening with women's health. So I think an important discussion is, where does women's health sit within the new cluster? If it's not another programme, where does that get embedded so it's sustainable? And working with the INTs and the neighbourhood working programme, because with the neighbourhood women's health guidance that's coming out, again, that's national intention to make sure that women can get access to care and support close to where they live. So I think that's something just to mention, and that feeds more into that outcomes discussion as well. How do we measure the effect of this, but woven through sustainable models of care into the future?
Final comment from me around the other bits asked at the beginning, so around the older population. So there is a very strong link with some work that we're already doing with the Ageing Well network across Dorset around strength and balance, and looking at osteoporosis and how to mitigate and prevention of that, and also group clinics for menopause, so bringing women together and giving them that supportive way, and that's a different model for how primary care could run. So it's not all digital, and that's a key thing, because we've always said, and Health Innovation Ethics, when I use the word innovation, I use it meaning a pathway, a drug, a new model of care, you know, as well as digital, because digital is not the answer for everybody in the population, and nor should it be. So there's a lot of work happening on that, and there's a lot of work that is continuing on that. And then the other question around engagement, particularly with girls and young women, so that was through the schools, and that was also through youth clubs. So we actually went out and physically did some focus groups in youth clubs with youth workers supporting, talking to younger girls without parents present, but with youth workers to make sure it was safe and it was appropriate. And we did face-to-face engagement that way. And that was a key thing to making sure we're hearing from people and getting as many of those views represented as we can.
Thanks very much. I was going to move on, but I'm going to. Forbes online has a question. Did you want to comment?
Yeah, okay, thank you. Just a comment, really. I mean, this is a really good piece of work, isn't it? And as you've alluded to, both general practice and wider integrated neighbourhood health teams are very interested in this work, and it's absolutely appropriate for it to be delivered there. So we're very engaged in the process. And I think it will sit under the Children and Women's Health chapter of the VISTA report. That seems to me where it sits in terms of long-term planning and delivery of women's and children's health services. The point is, there is a resource implication here, particularly in long-acting reversible contraception. Sadly, the funding at this point in time makes it difficult for many practices to continue to deliver this service. So we absolutely support the concept and the principle, but it's got to be supported by a fair resource to make it happen.
Thank you, Jonathan.
I don't know the door.
Yeah.
Right, and then I can.
Thank you. So I was just going to say thank you for the presentation. You came and presented at the Quality Conference last year for us, so very aware of this piece of work, and just thinking about that work with neighbourhoods, I think we could perhaps link up, so I'll pick up with you outside of this meeting. And I'm also really interested in the engagement that you did, and I'd like to hear a bit more about that as well.
Thanks, Bill.
Thanks. My comment was going to be, Helen, it was just kind of coming back to your point about where does this all sit within the cluster? I think that is, I think it's something we need to just give some thought to, because there is a risk, isn't there, that the reality will be there will be a team of people that's able to support this sort of work, but there'll be a smaller team over a bigger geography, and so therefore there is a risk therefore that the ICB isn't able to step into the space in the same way that it is. I think it'd be really good just to take this as an example, because there will be loads of examples of great work like this that's happening across the three ICBs and within the three systems. And just to work through the question about, so how do we make sure that we are able to sustain this and take it forward? Now, it might be that we have a different role in it and other people need to step in, but I just think there's something about, let's do that consciously rather than unconsciously, because change is happening, isn't it? And I think we just need to approach that in a really conscious way. I was going to ask the question about ongoing funding, because I think that sort of thing is important, and just reiterate, I think it was Dan's point about evaluation, and it's really hard, isn't it, to evaluate this at a population level. You've got some great evaluation there in terms of impact at an individual level, and that's like really important. But again, there is something about us just thinking through how we are better able to understand the population impact, some of the stuff that Siobhan was alluding to, and because that enabled us to have really good conversations at a macro level about where we use resource. So it's kind of obvious stuff, but it would be good to try and get into that as well, and understand what that evaluation might look like, and over what time period is it useful to do that.
And I just wanted to ask, as you're coming back, it was interesting, the things that you mentioned people would like closer to home, pelvic health, long-term effects of contraception, menopause. It's sort of interesting to ask you what gives you joy and what frustrates the hell out of you about achieving that type of shift, because this is what we're really interested in. We're interested in how do we see more things delivered in a suitable setting, rather than everyone have to go off to a hospital clinic. And any advice for us on what we're like as a system, and what you find helps those things to take place, and what you find can be a little bit frustrating or a barrier to it happening, would be interesting, please.
Yeah. Well, the short answer to that is listen to the podcast, because that will tell you both of those questions. Because the joy truly is the passionate people out there who really are committed to making change in this area. It's these people, but your GPs, your hospital doctors, nurses, managers, commissioners, and they talk passionately on the podcast about how committed they are to making sure women get a better experience. But they also talk about their frustrations in a very constructive way, and we did that on purpose to talk about what still needs to be done. And obviously a lot of it is resourcing, some of it is just practical stuff. And as I mentioned before, if you could do two things in one interaction, why are we finding that so hard to get that done? Because it seems so obvious to women, for clinical and various other reasons. There seems to be always a reason you can't.
Thank you. Leah, Helen, anything?
I would also completely agree. Thank you. I would also add to that yes, we had some funding for this programme, but the vast majority, I think, of what we didn't even rely on funding. It was about the way that people work. And we're so incredibly grateful to all of the staff, the clinicians, the operational staff, the women, everyone who worked on this, who didn't get paid for it. It was part of or on top of their day job, because they honestly feel that women deserve to have the best care. So I really believe that if we're talking about future models of care, it's not just about funding, it's about the way we work. And we can design things differently for actually quite a small amount of resource. It's just having people listen to what women are saying and what the people that have that experience are saying. But it's absolutely doable.
Just to really, as the system is sort of changing, I just think the provider collaborative is going to have to reset. And that's where primary care, the providers in Dorset come together. We're also going to have to redesign at some pace. So I'm just probably sort of saying this is ideally sort of suited to be part of that reset. So we'll follow up outside the meeting. Thank you. That's an opportunity.
Thank you all very much indeed. It's been really, really good, and we're all very grateful, if you can tell by all the smiley faces around the table. Thank you very much indeed.
Thanks, everyone. Thank you.
We'll move on to my update, and then hand over to Jonathan, I suppose we meet in the context, obviously, of uncertain economics at the moment because of the Iran war. On the whole, we have all hoped to see inflation and interest rates and the cost of living starting to ease, and that hopefully allows the government a bit of headroom to be able to do things. But in all likelihood, a very, very tight fiscal framework for the rest of this parliament, where we can't assume there's more money for the NHS than that already given. And that probably feels even stronger at the moment, doesn't it? The hopes that inflation and interest rates might come down temporarily, we could even see go the other way. The Chancellor does have some headroom in her numbers, but clearly there are a huge number of issues building up for her. By the time we get to the next budget, there's obviously a huge national debate happening, for example, about student loans. And so you can see a lot of things building up for the Chancellor. And I think the advice we receive is that the financial envelope that the NHS has been given is the financial envelope that the NHS has been given, and that it's very important that we move forward and ensure local accountability to deliver the numbers. For our cluster, one system is presently not in balance. The other two are, and so obviously we're doing a lot of work on that. Moving to the next layer of activity down, thank you for your help in signing off the board assurance frameworks, which we did outside of meetings, Jonathan and I. If there's any questions on that, obviously let me know. As I said last time, as we come to the end of these meetings in the present form of Dorset ICB or Somerset ICB or PSW ICB, the question will be, what happens next? Which of the diet of our work today will be discussed at cluster, and which of today's work will be discussed at place? And that's what we have to work through. And of course, we have some items to help take us into the governance arrangements as we move forward, and that will be an interesting arrangement. Jonathan and I had an all-day session yesterday with the 3 clusters of the Southwest region with NHS Southwest, and so we've been working through how will it work between region and the ICB on issues like performance, and when is the ICB ensuring that outcomes are being achieved through contracts, but when does that become performance management that the NHS England will lead on, and how are we joined at the hip for both of those? And obviously a lot of our discussion was, how do we equip ICBs to be the platforms for neighbourhood health and leftward shift? And I think this is the key to it, isn't it? We could very easily not give up things and act as the ICBs have always acted, but that would be a lost opportunity to become a really great strategic commissioner that radically transforms the way that resources are used and health occurs. And so we had a good discussion on that. And of course, all the clusters have issues of priorities around cardiovascular disease or cancer or respiratory, but then there are some things that vary around locality. Probably in Dorset and Somerset, dentistry is, it's high up everywhere, but it's particularly high up the agenda for us, isn't it? And how do we make sure that we work on some of those local priorities, as well as dealing with things at scale that may affect the whole region? I'm happy to comment later or take any questions, but over to you.
Thank you. Thank you, Rob. I'm going to take my report as usual, just as read, but just to pull out a few things. I mean, Rob's given a lot of the kind of the context, and just in terms of a comment on a few areas in here. So there are some specific areas where we've continued to receive national kind of guidance on a number of areas. So the cancer plan that we're kind of working through, what the implications of that are. I would just highlight just the point about dentistry, because I think it is really positive that whilst last year there was a real focus on urgent dentistry, that's now been rebalanced, because I think actually part of what we've always seen as the solution was getting routine dentistry back up and running in a more sort of sustainable service there. So I think that kind of recent move there is a really positive one in terms of our overall dental plan. The other thing I would just recognise with local authority colleagues is the kind of recent announcement around SEND, actually, and there is a significant amount of work to do now in a relatively short period of time to come up with the SEND improvement plans. I mean, for us, that's being done in the context, a tricky context actually, of massive organisational change and a requirement to have sort of draft plans in place by May. So it's a big challenge, and we will be doing 6 of them, because they will be place based. But I think again, it's a big and sticky issue, isn't it? The whole issue of SEND access generally and services. So I think it's a positive step forward. It's just making sure that we're able to give enough due attention to the next phase in the planning process and do that in a truly joined up way. So we will through the governance bring back the 6 plans into the cluster at some point during that governance process. So just kind of working that out. The other thing, and I'll comment on the transition programme for the ICB, and we've got a fuller update later in part B. But the direct commissioning delegation is, I think, just something that's worth noting here. So this is happening in April 2027, and effectively it increases the number of areas that the ICB will be responsible for directly commissioning, to include health and justice, vaccination and immunisation, and screening, which are currently held at NHS England level. So we will need to prepare for receiving that. It goes in parallel to the already delegated service around specialist commissioning, and then the primary care optometry dental commissioning delegation that's happened previously. Worth probably noting, because I think just for the board, the working assumption, so there's a national move to develop what they're calling offices of pan ICB commissioning, bit of a mouthful, for what is effectively a commissioning hub, which we kind of already have in the southwest. But effectively, it would be one ICB taking responsibility for the commissioning of all of those services on behalf of the 3 in the southwest. The working assumption is that that is our cluster, because we already host the hub for specialist commissioning and primary care. So just to note that, I think that as we go through the change process, this continues to move. There will be a kind of recommendations made more formally to the other clusters, because clearly they need to agree that. But I think what I'm sensing is that everybody is sort of saying that makes absolute sense. We already do regional ambulance commissioning, etc. So we're going to need to think about that, how that sits within the wider organisation, because effectively it's a kind of separate business unit to us. So, but I just wanted to note that A, that was coming, and B, that has a fairly significant implication for us. In terms of the change process, I suppose before I do that, just a couple of things kind of on Dorset specific, because whilst all this is happening, there is some massive change that is scheduled to happen in the Dorset system. You can see in the partner response. I mean, we've talked about it through an approval process within this board, but the EHR development across Dorset has now got the go ahead. It's a massively positive thing to be happening, but it's a massive amount of work that's going to kind of be happening now across the next few years, really, to go live in April 2028. So I just wanted to kind of note that, really, because it's been through the board process, but actually now got approval, and the work in earnest starts. And then also just noting, I guess, the delay in the coast building, and and Siobhan may want to comment on the implications of that. But obviously, in terms of, we're working that through in terms of the actual delay, the actual timeline. But there's implications for the CSR ambitions for this year and what's going to be happening in July. So again, I think it's probably just worth the board noting on that. We're not quite clear of the exact timeline at the moment, what the implications are, but we're working it through. I don't know, Siobhan, whether you want to add anything.
Just we should have clarity on the timelines by the end of March. It's obviously incredibly disappointing, and you know, I suppose I'm really sorry that we've got a delay. It came left field probably about 2.5-3 weeks ago, and we decided it was really important to be very clear with staff and our local communities that there was an issue, and then we'll work through. Our teams are seeing how much can move or change in spite of the delay in the building, but there is a potentially significant delay. It will not open in July.
Yeah, so working that through, but I think there is an implication because people are starting to lose anyway. But then they make choices, don't they, about where they go and where they access care. Yeah. So that to be worked through. But I think worth noting today. As I said, in terms of the ICB transition, I'll give a full update in part B. But there's a few things just to note. One is we now have a complete executive team. So we have appointed Becky Whale, who's the Deputy Director of Urgent Care and Emergency Care and Flow in Dorset, as the interim place director for ECP. So that's great. The national recruitment of the permanent appointment goes on. We've got interviews, I think, Monday week for that rate on the 23rd, and good response to that. So I think it's really positive that Becky is there. She knows the system, and she's moving into that from Monday actually. So good. So that's really good. The other thing, I think, the other two things on the change process, we've obviously got a very live voluntary redundancy scheme that is now starting to come to fruition with some really valued and long-standing colleagues who are going to be leaving us over the course of the next month to 6 weeks. So I wanted to acknowledge that we are now moving into a period of significant organisational change for the ICB, which is having an impact on colleagues right across the cluster. But within all of that, from a VR perspective, we have got some really valued members of staff who will be leaving us over the coming weeks, and so I wanted to pay tribute to them. Yes. There's a number of people in there who have given their life to the NHS actually, and have worked incredibly hard over an extended period of time, and we would normally be really celebrating the work that they have done, and we're doing that in a proportional way across the three clusters, but it is different from the way that we would normally do that, given that it's within a wider context. We're also launching formal consultation on the 18th, so next Wednesday, on the new structures. And again, I think just paying tribute to my colleagues here around the exec team who have created a new organisation actually, and as we go out to 45-day consultation, we genuinely want to get feedback from colleagues on their thoughts on new structures. They are quite different, we need to get that feedback from people, because I think we're quite conscious that we have done this and out of necessity as a small team. So that 45-day consultation is going to be really, really critical. But it's another big step in the change process, which is going to be hugely unsettling for folks. So to do that now as well as we can, as efficiently as we can over the course of the next few weeks and months is important. And I just wanted to note, Rob, your point about the board assurance statement. We were asked by NHS England to sign off a board assurance statement, which essentially said that we were in a place to be able to deliver all of the statutory functions as an ICB. We delayed doing that until we made sure that we had a structure where we knew that we did have the capability to do that. And so last week, we, by delegated authority, Rob and I signed off that statement. We put a slight caveat around point C, which was about us being able to manage the transition, because again, that work is very much underway. We've got a good process to do that. I think we're able to identify the risks, but I'm not sure at the point at which we signed that off that we were fully assured that we had all of that nailed down. I think part A and B, which is about understanding the functions and being confident that our new structure was affordable within the running cost allowance. We can absolutely say that now that we we have those structures nailed down. So I just wanted kind of
thank you.
Formal ratification, I suppose, on the part of the board. We submitted that already on delegated authority, but it was.
Can I take that as ratified, please? Thank you.
I think that was it.
Sam, did you want to comment on SEND at all that Jonathan mentioned, and sort of what you know and what you don't know at the moment?
I guess my only question would be, I saw the letter came out, didn't it? And I know that that's going to the DCSs across both councils. What would be really helpful to understand a little bit more about is when you reference the 6 plans needing to come back, what the kind of relationship between the cluster and the 6 plans at local authority level. Because I'm not hugely close to it, but I know that the DCS, Paul Dempsey and Dorset's obviously, but to kind of understand exactly what needs to happen over the next couple of months.
And I think it's one. So for us, I think there's some clarity to be gained. I mean, these are local authority based plans, aren't they? So there will need to be 6 of them, and we need to be able to facilitate our part in terms of being able to address the issues from a health perspective.
But it's just making sure they dovetail with the
absolutely
responsibility.
Yes, and I think now the work around making sure that we've got the right people involved and we're clear about the timeline so that we can properly sign these things off. I mean, I suppose if I'm talking slightly out of turn, I find it a bit strange that we've got a run to a plan in May for a SEND reform plan that goes on till 2035. So, but that's the ask. So, I think it's about doing this as well as we can.
I think David wanted to comment as well, and then I've got Forbes to come in.
Thank you. Just to add a bit more detail, some of the local authority colleagues. So Lucy Baker, who's our place director for Bath and North East Somerset, is also our cluster-wide lead for CYP, Children, Young People and SEND services. And she's already making contact with the directors of children's services and our local leads on the ground in Dorset to try and coordinate efforts and just make sure that things are lined up and we know what we need to do as our legacy ICBs and as the cluster ICB. So that's in train as well, Sam.
Thanks for that. Forbes.
Okay, thank you, and thank you for your reports. And I just want to echo Jonathan's comments about the loss of some very valuable people from the Dorset health system by nature of the reorganisation. My question, though, is about stakeholder communication. We're learning very piecemeal, and I accept there's all sorts of rules and limitations around what can be announced and when, but we're learning very piecemeal about people who are leaving and no idea about mitigation for the gaps that they will leave, many of them performing very important functions, certainly for my stakeholder group in general practice. And I just wondered if there's a way you could communicate who is leaving, perhaps, and when, and what, if there is any mitigation is available. So quite frankly, people know who to call.
Thank you. So I think it's really practical. Actually, just before I was coming here, we were just signing off for stakeholder communication. Just so it's more a general update. Let me take away the point about specifics, because I think it's really, those people are really, really valuable. A lot of them are doing really valuable work, and then all of a sudden
people want to know who to go to.
Absolutely. Let me. It's obviously there's a sensitivity involved in some of this stuff, because again, whilst people have applied for voluntary redundancy, they've still got a choice to make until they sign on the
and your restructure may have not yet identified who will take up the baton for a piece of work. And so that, but it's a good point that Forbes make.
So we've got a general stakeholder briefing that will go out over the next couple of days, probably by the end of the week. And let me just take away this specific point, Forbes, because it's a really good one.
Thank you, Adrian.
I was just going to observe that there was a NHS Dorset circulation, on which I get an update, which was basically a leavers schedule and a who to go to, even if it was the who to go to was a shared mailbox. So I found that useful. I don't know whether that's something that could be shared more broadly.
I'm sure. Thank you.
Thanks very much, Siobhan.
Just a linked point, I suppose. If I think about, so I chair the planned care group in Dorset. I'm assuming it carries on as it currently is at the moment, but it obviously has a small degree of support. But it's just like. So we're carrying on, but I haven't had any discussion about
definitely.
how it may
Exactly.
evolve.
Yes, and certainly, we've been focused on, we're going to come and talk about kind of board governance and the ICB board and the place-based partnerships, but there's a whole load of other things. We've got a very active internal conversation about our kind of management arrangements and how we start to bring those together. But we are doing some mapping of all this stuff to kind of work out how it.
If in doubt, carry on.
But I think
but it also probably fits with the reset with the provider collaborative.
Yeah.
So we've just got to work that
So I think it's
through.
if in that carry on and actually if risk evolves in that, then kind of shout, because we won't see it all. The reality is we won't see it all. We'll do as much as we can to be proactive and mitigate.
Yeah.
But I think the worst thing that people can do is just to try and carry on with yes, we just need to have those conversations when they emerge.
Dan, on the structures that you're consulting on, clearly you've had to go at pace. I'm just interested, how have you thought about using independent check and challenge on those structures? And I'm not trying to suggest the board should act executively, because that's your job. But how have you got kind of fresh pair of eyes on this?
It's a good question, and I mean, what we have done is a bit of check and challenge with other systems. So I've been in touch with Sam Allen, who is chief executive of kind of Northeast ICB, a big ICB in the Cumbria and the Northeast. Again, I think our reflection on some of that was it was really quite traditional. What we're trying to do is something that's quite different. So we have done some of that. I think we have been also working at incredible pace with this stuff, and it's sort of why the 45-day consultation is so important, because it isn't just it is genuinely a consultation with people to get kind of ideas, feedback, not just on the structure, but on the implications of the structure in terms of ways of working.
If there's anything any of us can do to help in the 45 days, especially with kind of non-NHS eyes.
Yes.
So just to introduce them.
Yeah.
Thank you.
Yes. To add to that, so I've been blatantly using my finance committee chairs as we've gone through this. So using Suzanne and Chris and across the pitch, just in terms of doing some of that check and challenge on my thinking as well. So it's as good as we're going to get, and we'll keep on doing that as we go through the next process as well.
Okay, thank you all very much. So one item before the break, the board assurance framework.
Yes, thank you. So hopefully relatively straightforward. So this is the board assurance framework, which we check every time we meet. It's been through the subcommittees for the elements of risk and monitoring that they need to do, and it's been through the risk and audit committee. You would know the history of this. I mention it every time that we established the board assurance framework. We identified needs for improvement, and obviously we would have reset the strategic risks at the beginning of the year, but it coincided with the announcements of ICB change and then ultimately clustering, which then would lead us into new governance arrangements and new strategic priorities, which would generate a new board assurance framework. So we took the decision that we would continue to monitor the strategic risks at a local level, but we won't go much further in terms of revisions and overhaul of the approach. So what you have here is the board assurance framework for this month, which has been reviewed and updated by relevant execs, some of whom have now left, so we need to thank them for their support in getting that done before they needed to move on. And it's been through the committees, so it's presented here to the board under its usual assurance process.
Thank you. What happens next, David, with the BAF? Do we have a cluster BAF? Do we have, just talk us through.
Yeah, well, there's work already underway in the transition governance work stream to review the board assurance framework, which will support the cluster ICB come together. We have, not surprisingly, very different approaches across the three current ICBs, so we do need to draw that together, and it will require board time and attention in terms of prioritising what are the big strategic tickets for the coming year, and the board assurance framework will be built off that. So it is a work stream that's in flight at the moment, but it will come under the cluster governance after this.
Adrian,
I need to share the conversation that we've been having at the transition committee. So yes, we create the new. And actually, I think from a Dorset only perspective, we're quite glad that there's the opportunity to reset, because we're not deeply invested in what we have here. It kind of covers our embarrassments and keeps us safe, but we know it needs to be innovated. But we have agreed that there'll be like a bit of a passporting system, so that once we've created what's right for the cluster, we will make sure that everything that's on the local registers will be represented or consciously decommissioned, so we don't just have something that gets dropped as part of the transition.
And I guess just to reflect for a second, how well do we feel the BAF has worked as you design what comes next? Is there any learning from the BAF that anyone wants to give? I mean, I suppose that Sam.
I think it's a good question, Robin. When I looked through and I kind of refreshed my memory about what some of the controls and the mitigations were, it's a reminder that it's only as good as the level of engagement with it.
Yeah.
And I think possibly may not have always made as much use of the wider partnership input. So the health and equalities one I scanned through very quickly. It's got a couple of boards on there that don't meet anymore. But there's a parallel conversation going on about the expansion of health literacy training and encouraging organisations to really adopt that and embed it as part of their customer service ethos, for want of a better word. That's a really important key control. So unless partners make the ICB aware of all of that scope of work, then it can be sometimes a little bit narrow. My only comment.
Dan.
But sorry, a kind of broken record point. I think we've done the right thing with the BAF, that we got it to a point and we sort of didn't freeze it because we kept it live, but we didn't keep tinkering with the format. I guess my challenge back to us all would be, I'm not sure we've got a BAF. I think we've got a strategic risk register and a corporate risk register that speak to each other, and it's therefore light on control and assurance. And as you get a massive geographical area with places, the control and the assurance bit will be much more important. So there's something for me on corporate versus strategic risk and how they feed in. And the board always talked about that through the development as we did it 12 months ago, probably longer.
Yeah.
But there will be a time to revisit it.
Yeah, I think that's the interesting thing to think through, isn't it? Lots of large organisations or groups or systems don't have a BAF. And it's because programs are managed through performance management, risks are managed through the risk register, including an elevated risk register. We do have the BAF in the NHS world because we should ask ourselves the question, coming out of all these different risks and different performance issues, are there some things we need to be aware of? Yeah. We might not have the capacity, even across implementing EHR or health inequalities or all the other things we see. And that's the hard bit to achieve, isn't it? Where it becomes about that. It becomes, what do the other things not do in order that we have this strategic overview of, have we got a risk that will stop us delivering, which somehow isn't captured in any individual performance or risk item. Yeah. Does that make sense?
It does. And when we started as the ICB, the previous CCG didn't have a BAF, a board assurance framework, so we had to create it. Yeah. And through the engagement, through the development work, this is where we got to. And taking Dan's point, we recognised after a couple of sort of 3 or 4 goes through this, it wasn't achieving what we needed it to achieve. Mm. It got us to a good place, and we had something now to build on. And that sort of insight took us into the period where the massive organisational change was coming through. So it wasn't worth the additional effort, but we definitely need to take that into the next phase of the changes that are coming through.
And if ever an organisation needs a BAF, it's probably a cluster.
Yes, absolutely, no question.
And so in a way, and some advice from the audit committees, Dan, about how we get this right and pitch it for what we most need, I think would be really useful.
And it's worth saying that Somerset and BSW are well versed in doing this and using this, so they'll come with a lot more experience than we've had in Dorset.
Thank you. Any questions?
I was just going to moderate the last comment because I think from a Somerset perspective, we have
this Somerset.
But we have spent, like, I think, quite a lot of time as a board over the last 4 years trying to iterate the BAF and trying to get our heads around what actually is it and what does it actually help us to do. So I'm hoping that there is an element of bringing the 3 together. Yeah. But taking Dan's point, this might be something where we just want to look up and out and go, how do we reset this and learn from others about what good looks like? Because there's a whole industry in here. There's an awful lot of work getting to this point. but if it's not useful, then that's not helpful, is it? So I think there's a moment for it, really. I'm not sure any of us have got
And
it
I would
right.
really think, I'd think from scratch. We had a good discussion at the regional event yesterday about capital, didn't we?
Yeah.
And the importance of capital. And yet it's a bit of a nebulous thing in terms of capacity. So, Siobhan, you have an individual risk around the coast building, but as a cluster, do we have the right capabilities to be able to not only do coast, but to get repair and maintenance and estate management and design neighbourhoods? There's a BAF risk there about not getting our assets right. Does that make sense? And I think it's trying to elevate to what does it tell us that other things don't?
That aggregation.
Yeah.
If we look at other areas for me around cyber particularly, it's like how do we consider that as a cluster versus it looks fine in one area, but we might be introducing another set of risks somewhere else that we're cognizant of. So I think there's more to do in that sense from the aggregation.
Yes. So. And I think there are some particular risks because actually thinking of cyber, it isn't completely certain yet what's in model region and what's national. And so there's a bit of extra risk at the moment as we try to aggregate what our key risks are. Adrian.
Never like to disagree with an unaccepted colleague in open forum, but there's something for me which is to be really careful about it becoming aggregation, because I think it's different. This is not the sum of the different CRRs. And having done risk and audit chair for whatever it was 9 months last year, the thing that frustrated me most about that was, it was trying to achieve too many different purposes and probably not its core purpose. And there was a lot of duplication between things that should really be in the corporate risk register were starting to appear in the BAF, and then there were things that were the other way around as well. So, however we define it, I think it's unlikely that it would be an aggregation point.
I mean, aggregate, like if we look at data sets in my world as an example, you might look at something and say, well, that's just official, but you combine it with other sets of data and you look at that and you think, well, that now becomes secrets because the sheer volume of it together, rather than saying we're going to aggregate everything together and look at it as a whole. So I think it's looking across the system and saying we've got a set of risks here. How are we going to assure ourselves that it's all equitable, or we're dealing with it in a consistent way, rather than saying there's lots of anyway. There's a debate there to be had, I think.
But probably a one pager from you at some point on our operating model and what we want the BAF to do, what we want performance management to do, and what we want the risk register to do. That would probably be a helpful refresh, the design that we get those things right. That work.
Yeah, we turn that away because I think we've got to think about purpose before we then launch into what the template looks like. Because we'll start designing something without being clear about what it is we're trying to achieve.
Yeah, thank you. A good discussion. Should we have a break? Thank you very much. Updates from committees probably just be useful as we go through to signal if something else is coming later on. So Adrian, you're going to report on finance, but we just make sure that Alison knows when she's going to report some of her stuff later.
Yeah.
So we're coordinated.
Okay.
Over to you.
Okay, so you have a bumper number of escalation reports from Finance Committee because we've been having so much fun over the quarter. The first of the 2 pages in here covers 3 meetings, 26th of Jan, 30th of Jan, 9th of February. I wasn't going to talk to that because all of the relevant matters have already been escalated to earlier meetings of the board, particularly the approval of the EHR contract, the annual plan, etc. I was going to concentrate my comments on the meeting of the 26th of February, which is the more recent one. So within that, we looked at a business case approval for the new Wareham GP surgery. There's a more detailed paper on that, Rob, later in part 2 meeting. I think for this part, just to highlight that it's a really good set of proposals. We had 1 or 2 specific queries for the team around the commercials, so we didn't feel that we were quite in a position to recommend to board that that be approved. But hopefully on the basis of what we hear this afternoon, we'll be able to get a mandate and delegation to approve that at Finance Committee subject to. So we'll come back to that this afternoon if that's okay. We also went through the community dental services contract, which we were happy with and happy to recommend, but that's also for presentation later this afternoon. Yep. So I think we can have a detailed conversation on that. And then the business actually was refreshingly business as usual at the February conference. So we're talking about 25-26 year end and 26-27 fast start to the plan we've just signed off. And we had good updates on both from the ICB team, but also from the provider teams. Slightly different construct next year, but everybody remains equally interested in delivering the total of the commissioned budgets effectively. I think we're feeling increasingly optimistic that we will land 25-6 in line with the latest forecast, which is on plan, and 26-27, you know, we have commitment to the efficiencies that we need. So nothing really to escalate. Those were the main points that we discussed.
Thanks very much. Any questions for Adrian? When I observed the NHS England board, the public board at BCP, they had a paper on ICB financial performance for the year, and obviously dealing with deficits and overspends. And there at the top of the list with the best financial outturn for the year was Dorset ICB. And we came a long way, didn't we? Because we were not there a while ago. And so, you know, for all the meetings that have taken place for everybody, Somerset were not far behind. I'll just let you know that, but I'm afraid they were behind. DSW a bit further up.
It's fine.
But really well done. Yeah, well done everybody for the year. An awful lot of hard work went into the governance of financial recovery, and actually not just because I was in the room observing their meeting, but Dorset was praised by the NHS England board for the very good job it's done on recovering its finances. So I ought to look everyone in the whites of the eye and say well done. It's really well done. Shall we move on to the outcomes committee, please?
Thanks, Rob.
when the Strategic Outcomes Committee was first set up, it was to drive the fact that what we were trying to do had to be measured by outcomes, and that the measurability of that was something that the committee was particularly scrutinising. I'm saying this because obviously this committee is ending, it's handing over to something else. So this is my kind of summing up of how far we got on that one. In some areas we have performed very well, and I think the Future Care programme is one where the committee felt and feels from, you'll see from the report here, that the monitoring of genuine impact could be seen through the way they went about it. We had concerns, on the other hand, about the Integrated Neighbourhood Teams presentation, where it seemed to us that there was a series of things that they had done, and then a series of slides showing supposed improvements in a number of areas, and there was no correlation between them. So this was about, as Dan says, about output rather than outcomes. And therefore what they were doing, they were suggesting, was leading to this, when we couldn't see any actual correlation between what they said they were doing and what they said the impact was, because they didn't match up in our view. So I think in that sense, the Outcomes Committee, who has for ages tried to say we must have these clear outcomes, has failed in that programme, or at least we keep saying it, but we haven't yet got that right on that programme. And this is something I think for you to take forward into the new cluster, that there is something fundamentally wrong in the outcomes that we're trying to achieve in the integrated neighbourhood programmes and how they're trying to actually show that those are happening, because they don't match up. And that was the core of a lot of our discussion that day. You can see we talked about the women's health, but you just had that presentation as well. And that's one of the things to take forward. And I think the other area where we need to pick it up and make sure that it's still going forward is the mental health transformation improvement plans, particularly the children and young people's, because there was a lot of work put into that in the early stages. And at the time that happened, there was concern about cultural issues to make it happen and outcomes there. And I think that's another one that I would ask that going forward, whoever's in this kind of role and across the cluster takes it, make sure that there's a close eye on that going forward. And there's where we come back to the conversation we had earlier that you were raising, Rob, about strategic outcomes as against transformation and how as commissioners we manage that. So I think my final report, or the final report that we have here, sums up both areas where it has been successful, and we've got a model there that I think could be used in other areas, and areas where we have failed to move it towards the outcomes effectively. I don't know if everybody else would agree with me. Adrian, you were nodding, so have you any other comments on that?
I always agree with you. It was a good and rich discussion about integrated neighbourhood teams. I mean, I think that there was no lack of belief in what we're trying to achieve, and no criticism of any of the things that have been done so far in terms of implementation activity. But there was real appetite from the committee, including you from the chair, me as a participant, for more tangible focus on the outcomes. Because I think some of the risks that we called out when we were, as a board, trying to sign off the funding envelope are still there. Kind of a lot of the initial focus has been on setting up teams, having meetings, smoothing communication pathways, all of which is necessary, none of which is sufficient to actually achieve some of that leftward shift. And I think that's where some of the restlessness was.
And I think it's partly because of the wide participation of stakeholders within that. Yeah. And I would say, Sam, this is one that is going to be very similar to this one, and it's going to be absolutely crucial that you get the partners together in a way that can manage the outcomes and set the outcomes quite clearly from the beginning. Because if you don't do that, you'll be in where we are with the integrated neighbourhood teams. Because actually, I don't know that I can, as chair of the committee, and you'll probably agree with me, Adrian, I don't know that I can give a definitive view as assurance, perhaps, as to whether the integrated neighbourhood teams is making appropriate progress towards their outcomes. I simply can't, from what's presented to the committee. And that was the point we were making about this at the time. So that's one of my main concerns going forward, is I'm not sure we have completely embedded the kind of outcome mentality that you're going to need in strategic commissioning going forward.
Yeah, it's really interesting. And we might wanted to have some actions around that, but I think Dawn was first and then Siobhan.
So thank you for that feedback. And we've got Forbes on here, is obviously one of the leads for the programme. But the last integrated neighbourhood meeting, we went through some of those outcome measures. The ones that we've got at the moment are quite broad ones. So they're about, reducing the number of people that come in as an emergency admission, about prescribing activity. And we were talking there about how do we kind of allocate those metrics to the work that's happening.
That was my point.
To hear that. And we also had to talk about some more experience measures being in there about what does it feel like. The other thing that's happened within the neighbourhood space is we've identified the first cohort of individuals that we're going to be working with, which is about 2,500 of our population that have a high use of services, and agreed what those interventions are going to be within primary care. So I think once that piece of work starts off, there'll be much more clear correlation about actually this is the activity that was being seen at baseline from these people using services. The intervention's gone in, and then this is where we are now. Of course, Forbes may want.
Yeah, thank you, Forbes.
Yeah, thank you. And just listening to the comments that have been made, and I understand where people are coming from. And I don't want to come across as being too defensive, but I think if Matthew was here, he'd be saying this. Instead of looking at outcome, did you look at input to the programme at all? Okay, I wasn't involved in the conversation. Because if you look at the input to the programme, the Newtons was brought in. We had a lot of senior executive time focusing specifically on the future, the programme you refer to. And also, Patricia was SRO. So there was slightly different emphasis against, quite frankly, very tangible outcomes as well.
Yep.
Whereas in the neighbourhood team programme, we're looking at population outcomes, which are delivered in a different way and do take longer. We absolutely have to get there. And the other thing is about delivering the left shift. A left shift has to happen, and it will be about the system redesign in order to support that, not just the people on the ground working harder.
Oh, sorry. Hey, did you want to answer that?
Yeah, I think it was a general point I was trying to make, Forbes, about the effectiveness of the committee. But I agree with you absolutely on the Newton, and they had a model that they could simply transfer from other places that had worked, and therefore it was easy for them. I just don't like reports where it says we have achieved this, or at least gives us graphs which says this has happened, and then describes what they've done, and you can't link what they've done to actually what they say has happened, because there actually is no link that because of what they've done, this has happened. And I just think the metrics, and Dawn's picked it up already, just need to look at the metrics again. I would rather that we didn't have these graphs which show an improvement somewhere, which actually the INT programme hasn't had an impact on. It's something else that has led to that. So I just think don't showcase something that you're not sure is actually what you've achieved, because it's down to lots of other factors. And I agree with you about population health. It's much more difficult thing than a very tight programme like Future Care. I absolutely take your point there.
I went to the last neighbourhood programme board, and actually I wasn't going to say anything, and then of course I didn't I, Forbes? But actually I really enjoyed being there. And what I would say, this programme, we're sort of in the, we're really at the forefront of this. We're with the national team around neighbourhood development. There's been a lot of metrics, a lot of focus on governance and process, which I think has actually been part of the national drive around it. And I think what I observed in the programme board was that real challenge around a slight reset, looking at cohorts, looking at outcomes, looking at real tangible measures. And actually what we've learned from Newton is they brought us to a point where you have one version of the truth in terms of the measures. And that's what we're just grappling with, I think, in terms of the detail around the metrics on the neighbourhood programme. So I think you're sort of in the ballpark for where we are in terms of evolution. But I think we've recognised that, and I see people that are really grappling with that at the moment.
But on a broader form, all I'm saying is it's something we need to look out for in the future with other programmes, because it's not well embedded.
Well, then it's going to become really key, isn't it? Because if we believe that, want of a better word, left shift activity, and that we're going to invest in a neighbourhood programme or something else, we're going to have to work out when does the money come out of the other end that it saves? And if we're going to negotiate with you, Siobhan, or with you, Dawn, about I'm making this up as I go along. Sam, you always talk about the work that Dorset did on cardiovascular identification, which reduced the number of strokes. If we're going to have a discussion which says we think you're going to have a bit less stroke activity, so that's going to be reflected in future contracts and future, we need certainty on the numbers of the work that's going into the prevention. And so in a way, I think it's helpful, Kay, that you've raised this, because it's going to be pretty key to the way the ICB works, that we have a sense that we can put tangible numbers and targets around these things, and at that stage we're identifying where we think the money will come out that helps fund it, even if there's a lag of a couple of years. Does that make sense?
It does, but I would say there will be some money out, but there's also a resource shift.
Yeah.
So actually from a hospital, you know, people who work currently in hospitals may well then be working in very different settings across Dorset.
Yeah.
You know, so actually it's not just about.
Yes. No, I get that. I suppose the accountant in me is saying those things ought to be identified at initiation. And even if they change with the experience of delivery, we have a plan of what we think happens to the resources in the light of that activity.
Yeah, I was just going to say, I think I mean, part of what we've been considering as we build the new capability of the ICB is some of those areas where I think we need to dial up that capability. So things like, you know, having some folk that can do proper operational research where they can connect kind of, you know, what happens to outcomes. You know, the data is obviously really key to that, and you know, the sort of evaluative work as well, like linking with partners like the Health Innovation Networks, but actually building our own capability. So when you see the structures, you will see that reflected in there, because I think it's an area that we need to be much better at as an ICB, but supporting the wider systems with that as well.
I've just had an email asking me if I can chair a session on this at the NHS Confed. So Jonathan and Alison.
That's fine. We can put up a structure.
Now, can we just talk about governance? Oh, sorry, Sam, and then I'll come back to governance.
Yeah, just a tiny comment going to Kay's observation. I sort of feel a little bit of empathy health program, because it's being asked to do an awful lot prevention. So there's a bit of a challenge as we system changing, going to place-based partnership discipline really pins down through a theory of change exactly what the Neighbourhood Health Programme are going to deliver, which outcomes, because it's lifting a lot and we need to be far more specific, and that will then give you numbers, hopefully, Chair, pop up, and they'll always be cash releasing. I do have a work times in business cases which are cash releasing. We need to keep challenging that, and if it's resource transfer, let's count it. Tally of that.
Thank you. Paula, did you want to comment?
Yes, I really just wanted to follow on from Sam, really, to say that for the voluntary sector, we're going to be more involved probably in neighbourhood health. And often we're furthest away from those outcomes when it comes to measuring. And so often the input, though valued, isn't necessarily able to be showing in the metrics. And I do think there is a need for some universal outcomes that cut right across all of the outcomes that are being looked at, and patient activation is a perfect example of those kind of metrics that can be used, so that the voluntary sector can also demonstrate its part that it plays in improving waiting times, improving attendance at A&E. But I think they need to do it through showing patient activation, and we need to see those outcomes being spread right across the board.
Thank you. Thank you very much. Now, just to tidy up what this tells us about next steps on governance. Liz, do we think there'll be one more meeting of the existing committees, or do you think the other side of April will move straight to cluster committees? What's our thinking at the moment?
We have been tasked with moving into cluster governance arrangements in April.
Yeah.
And I think that for the assurance committees, we can see that working. We're working on a pathway to that at the moment. I think maybe there might be around our decision committee, so finance, we may need to rely on some of our existing governance if there are any things that we feel that our new systems won't be robust enough to take through the cluster governance in the April meeting, but then running fully formed from June.
So for the committees so far, finance, there will be a new finance committee at cluster level. For outcomes, what happens next, and where would something like integrated neighbourhood teams be discussed? Will they be discussed at place level according to where they are? Do we think there will be a committee and a home to discuss those at cluster level?
I mean, I think they sort of link into a commissioning type committee.
Yeah.
We just wanted to flag it. Also, they report into the provider collaborators currently.
But I'm just thinking about ICB governance, and of course for the next year, the acutes remain part of ICB governance before we merge, when actually we then probably move to a harder commissioner provider split. But I hear what you're saying, and we don't want to duplicate necessarily. But something like Kay's question on have we got the right metrics to be able to measure the integrated? You think that would be at the commissioning?
So it's in development.
I'm going to ask this as we go along. Sorry.
Yeah, but there is work going on around a commissioning and population health improvement committee.
Yeah,
which is where this would come together, because the outcomes aren't a destination in themselves; it's the population health improvement over time that we want to see. So it would naturally sit in there. And you're quite right about it's a wicked problem getting outcome measures right, because if you've got your outcome measures right, you won't see the change month to month. You'll see it over a period of time. So you've got to have some attendant measures, some KPIs that demonstrate progress towards. And some of those are input-output measures. But it's recognising, Kay, as you're saying, that one thing is measuring one thing and the other is measuring the other. And we need to know if we're making progress towards the outcomes until we get to an outcome with, etc. So there's a lot of sort of sophistication around it that we're building into our thinking, and the way we're trying to build up our teams and build up the specialist skills, as Jonathan has said. So, but there is a committee in planning that would pick this
and
up.
at the end of the part 2 meeting today, we have got this sort of item, haven't we, about what are the things we most want to highlight today that we need to make sure are taken forward, even if we work out how that's done down the line. But can we properly align outcomes from leftward shift? And what's that? It's a good question, Kay, and we might want to highlight that at the end and make sure that we take that forward in the new governance structure.
I was just going to say, I think, because I think it's being clear about who does what within all this, isn't it? So neighbourhood health is a massive enabler to trying to achieve. The delivery of that clearly sits within the provider collaborative. There's a question for us about how we can better commission and incentivise providers to make the sort of shifts that need to be made. So and that's the bit I guess that we need to get into, isn't it? So kind of this is the ambition. This is what we're trying to achieve. We commission that in a particular way now, or we contract for it in a particular way. Should we be doing some other things to be able to really incentivise the scale of change that we know that we need to make? So I think it's really important that we're all on the pitch, but actually we're all clear about what our respective roles are whilst we're there as well.
I think that thing about incentives is going to be
because this is about incentives, isn't it?
It is entirely about incentives.
What I would say was sometimes it's really difficult to align a specific measure to a specific piece of work. So if you think about all of the work that we're doing across Dorset at the moment, we're doing integrated neighbourhood teams, we're doing future care, there's work happening in all of the providers to improve, and we will see metrics shift, but sometimes it's really difficult to untangle which actions actually cause that metric to shift. So I think that's part of the problem that we have, but all of us are working on the sort of same sort of metrics that we look at, sort of, attendances at ED, length of admissions, all of those things. So sometimes it's really difficult to pin it down to a specific action in a programme.
And just isn't there an archetype that's coming out around neighbourhoods that we're expecting any minute yesterday? And also there are the neighbourhood and multi-neighbourhood contract forms, which from a commissioning perspective will give some support, obviously, in this area. And then I think when we discuss Vista Health later this afternoon, this is obviously a key theme, isn't it, for quite rapid change and transformation over the coming year 2, 3.
But I think being bold on incentives is not easy.
No.
Yeah, you remember we would have all been on these conferences where we've heard the example from America that when hospital groups were incentivized that they would earn more money the fewer diabetic amputations they made, rather than being paid more money for doing more. They created community diabetes schemes that reduced the number of amputations, and so the hospitals earned money because they were doing less work. And that is a really interesting question. Let's see, Louise. Jonathan didn't shoot me down. I mean, I do like to talk loud. Should we incentivize councils to reduce NCRs by you get more better care fund if they're reduced, and if they're not reduced, you don't get better care. I mean, these are real incentives to sort of think about, and I do hope we can be bold on that. Forbes.
Yeah, just pick up on your last point, Rob, because I think that is exactly the conversation that we should be having. As a system, what we need to do really is move to commissioning for shared outcomes. So the incentive is to improve health of the population rather than intervene at an individual level. The trouble is the whole system is set up to sort of promote intervention for an individual, and the training as well, particularly within the acute sector. That's nobody's fault. That is just the way the system is. And of course, when the politicians see that going off a bit, then there's major pressure on health systems to correct that, particularly around 18 weeks and 4 hours. If we can move to what I would say is a more mature population outcomes model where the system is working towards shared outcomes, you can start to redress that balance, and your workforce plan and your finance plan needs to support that. And we need to be brave and hold the line.
Yeah. Some of that is going to need to be at place committee stroke forum, isn't it? So I hear what you say about the cluster commissioning, but it's going to need to be at those. Isn't it? That was really helpful, Kay, to raise that. Thank you very much. Paula, I think I brought you in earlier. I'm just double checking I haven't missed you.
Okay. Legacy hand.
Legacy hand. Thank you. Thank you, John. We are people.
Me again.
Hey,
Because Carl was enjoying himself in Japan, so
Carl
shared this one as well. I don't think there's much to say here because we discussed this earlier, because the People Committee now has the specific remit to check the risks with regard to transition. And we looked at the 2 risks, particularly with capacity and capability, and we're all right at the minute, but it's hard to see where we'll get to at the end of this as we go along. We move into the next phase, particularly with CR. So that's really, we've already discussed this a little bit this morning. So unless anyone has any questions, I don't have anything else to add to that one.
Any question? At the moment, we don't have a People Committee or cluster, but we've identified that there will be some people issues that we need to put into the remit of one of the committees, REMCOM or another, because you and I have been meeting staff networks, for example. It's important that NEDs can triangulate issues about organisational development. So we are not a large organisation in employee terms, but there are some things for the board to be involved in, and we've identified that we need to do that. We haven't got a specific committee identified at the moment, but it's going to need to be in the TOR. Rhiannon.
Yeah, it was just to that point. We did have a bit of it, or maybe I've had it separately with Emma, potentially, I don't know. I think that point that you were just making is really important, because actually the kind of changing nature of skills, approaches, I've said it before, they're not going to happen by magic. That OD piece for the whole organisation, not just the exec team, it is really important, because everybody's got to be doing different stuff, haven't they?
Alison, did you have any thoughts? First, we had a special moment.
We were just.
I'm waiting for Jonathan to give you a bit of cake.
Yeah, we were just having a kind of conversation about actually whether the internal people agenda could sit within the kind of finance and resources committee, and we could take it away. So because obviously REMCOM's got a specific set of things to do in terms of, you know, it's so.
And one of the REMCOMs did do the wider people stuff. It was BSW, wasn't it?
Yeah.
But yeah, no. So that's
we'll take
that's to be identified. Thank you very much. Thanks for that, Kay. And then what's the last one?
Quality.
Yes, thank you.
I guess we set the scene in just having a little bit of thought to the challenging job of at cluster level, what to measure, how to measure, the kind of overview of quality and safety, and anything that might have been in the Dorset committee that, you know, could be considered in the making of how we do that, or how the cluster does that going forward. I'm not saying we came to any conclusions, but just made sure we had that forefront in our mind. Just picking up on oscillation, I suppose I would use the word, of the former Quality, Safety and Experience Committee and the Quality and Commissioning Committee. I think we've gone from data heavy to the narrative heavy, and we lost some of the traction in terms of the important need for some data, but not to overwhelm and getting that right when you've got a whole system. I'm sure you're giving it lots of thought, but it will need some thought, won't it? So I did just want to say that we did sign off. There's a sort of underpinning important piece, quality group in the Dorset footprint. I don't know if that exists in the other parts of the cluster. That's kind of does the job of really monitoring at that kind of lower level. Obviously, that won't necessarily be the job of the ICB, but there's something in that space. So we did sign off some terms of reference, but subject to what that might mean in the context of where the cluster gets to on this. I think just as a good news story, there has been a Dorset hydration project that's been recognised nationally and is being rolled out nationally. That's really good news. We had quite a bit of discussion about the maternity advice line, in that you think about that as the front door of maternity, and maternity being in such purview at the moment nationally, across the whole UK actually. What we recognise that there are yet no metrics to which we monitor ourselves. If we think about 111, you know, time to response, timeliness and quality actually, that exists in that maternity advice line space. It doesn't yet exist. So we had some conversation, didn't we, about even if it takes some time for something to come out nationally, perhaps as a cluster, we need to be thinking about setting some metrics going forward. So I think that was a helpful conversation. We also talked about, Dawn was helpfully reminding us about the potential reopening of Yeovil and the impact on the workforce over on the Dorset side. So just she's preparing and planning and thinking around that. So we took some assurance from that. We also heard that there'd been a positive SEND inspection in BCP area. So I think that's really good to hear. We also had a presentation by Pharmacy First, which was great in terms of all the brilliant things that are happening already, but also underutilisation of Pharmacy First. But I'm going to overlay that with the fragility around pharmacy, particularly with the Chahoots situation. So there's more to optimise there, but there's fragility. So it's that kind of issue. And I'm sure Forbes might say, but the primary care delivery group obviously flagged concerns around the change with the ICB and the pharmacy issue as well.
Thanks very much. Any questions or comments? And this drops into the new quality committee. Just to, thank you. Thanks very much. And Dawn, perhaps we can place on record our thanks to Dorset County for the work they did on maternity. It's been a success story with Yeovil reopening and managing to start again, and they deserve a lot of credit, but so does Dorset County for the brilliant work that you did stepping in. So maybe you can pass on our thanks to your board and your staff for what they did. Okay, thank you very much. So we are on to the integrated. I'm sorry that took longer, but I wanted to sort of be a bit tasky about making sure we know what we're doing next. David, the integrated performance report. Oh, sorry, Dean, forgive me.
Still me.
It's still you.
Performance report.
Come on.
for the
matrix working, mate.
The ICB. I think you mentioned kind of the recognition for the good financial performance that we're ending the year with Dorset, and I think that links to the operational performance, which we have seen be really good across Dorset over the 3 years that we have been an ICB. So I think we've now started that journey of recovery of the financial side, which potentially has been at the expense of some of the operational costs that we have got in place. So it's good to see that we haven't declined on operational performance as we have recovered our financial position. So I think that's really important to say. So just in terms of the metrics that we look at from a planning and the national guidance, kind of the elective performance you'll see is really strong, particularly the cancer performance. You'll see that all of the metrics on cancer have turned green, which is a remarkable position given everything that has happened over the last year, in addition to reducing the long waiters as well. So we're going to end the year with no patients waiting over 65 weeks. And it's not long since we were talking about 104-week waiters. And in Dorset, we were at the end of March, were waiting over 65 weeks, even those that have needed kind of short supply material as well, where we had got kind of a handful going over 65 weeks because of that. So I think that's a particular kind of thing to celebrate within Dorset. We're still seeing during March a reduction in the 18 weeks position, and kind of it has bounced around over the winter period, but we are improving that, and there's a particular concerted effort during March to deliver that. Again, in mental health, we see continued strong delivery of the targets, and in primary care, we're now kind of showing the good performance that we've got on dental. Now, dental does look red on the reports, but it's only red because we have the capacity for people to be seen urgently. We've now not got enough people who want to be seen urgently to meet those numbers, which is why it's showing red. So we have the capacity. We have contracted with kind of 29 different providers for that, and that is now in place. Urgent emergency care, winter is always challenging for urgent emergency care, and we particularly had a challenging February this year. It was particularly difficult. We're seeing improvements in that in March. We have seen kind of ambulance response times now in Dorset have been since February under 30 minutes, which is the target. And across the southwest in March, we are currently under the 30 minutes for the category 2 response times, which is where 60% of the activity is for it. And we see that continually improving from January. So I think, including the performance report for the last one for this board, it's strong in Dorset, and thank you for the continued effort from our providers in delivering that, not just in this year, but over the three and a half years since we've become ICB.
And thanks for highlighting that. Louise.
Thanks, Chair. I just wanted to make reference to the dentistry numbers, just to say that we at Healthwatch are still hearing a number, of people every month who cannot get urgent appointments. So I think, there is the need out there, but people still aren't being able to get that need met. I just wanted to raise that point.
Yeah, no, it's a really good point to raise. Do you want to comment on our approach to trying to come up with some new solutions?
Yeah, well, yeah. I mean, I think dentistry is one really good example when you look across the cluster.
Yeah.
Of there's some innovative stuff that's happening.
Yeah.
That you sort of wonder, well, if that's happening there, why is it not happening here? So I think there's an opportunity to do that. I think there is a specific thing going on here in Dorset about there's available capacity, but we don't seem to be signposting people into it. So I do think there's something for us just to pick up there, because that seems a bit of a sort of anomaly within Dorset. As I said earlier, I think there has been a real focus on urgent for the last 12 months, but for obvious reasons. And I think the slight change in the national position gives us the opportunity to use some of that resource actually to kind of bolster routine dental capacity across the system as well. So I think, I'm not being complacent about it. I think this is a massive area of priority for us.
Something we should probably have quite early at the cluster board.
Definitely. Yeah.
Thank you very much. Thanks for asking that, Louise. Siobhan.
I suppose The only area you didn't mention was urgent and emergency care, and I just think, I had my board yesterday, I would just say it is a major focus of attention. And actually our performance, we've been quite challenged, especially in month 10 that you're looking at here. There's been sprints, and people may not know that, but sprints to year end. So an elective sprint and an urgent and emergency care sprint and a number of other sprints. But I would say that in week 3 of a 6-week sprint, we are now making some progress and traction, which is good. And our performance on Sunday began with a 7, which was very good. But it's been tough, you know, and that is, I think this board, it would be really nice if you just recognise the amount of work that is going on across the system in those pressured pathways. And that's from primary care, through community, through our future care programme, through the wards, through the front ends of hospitals. But it's been really quite a tough January.
Thank you.
Which is what you're looking at now.
This is probably where I got completely the wrong idea. Is there a methodology change at some point that UTC attendance doesn't count within the UEC numbers, or if I got that completely wrong? It was something said yesterday, and I wanted to follow up with you.
Yeah, it relates to the designation of urgent treatment centres rather than minor injury units.
Thank you.
One not being counted at a point in time. So I think in Dorset, I think it's not.
It doesn't affect us.
Thank you. Is that
we still do have MIUs which are still mapped into particularly Dorset County's numbers. There has been a suggestion over the last, I think it's the last 2 planning rounds, that they would stop counting the MIU data when they've realised the impact of it. That hasn't taken.
I guess that's what I wanted to tease out and understand. Thank you.
It's the move to what's called the emergency care data set, ECDS, which is where they're going to start counting the figures, and you can only submit that if you're a UTC, not an MIU. So that's when the change comes, but they haven't implemented it yet.
Thank you. That's really hard. And you must be aware of this, Dawn, and you very. All right.
Can I just ask a follow-up question? Because I was looking at that point at page 97. I just wondered, is there anything meaningful going on in terms of engagement with the public on this? Because it doesn't come out in the narrative on page 97. So are we doing a significant piece of work in terms of working with the public in terms of their behaviours? I mean, I see the signs when I drive into places that sort of say only ring, you know, whatever it might be, 111. But is there anything meaningful going on in terms of work streams on that?
I'd probably look to Dean. I mean, we're obviously doing quite a lot as UHD, just generally because of the changes, you know, that actually. So we have been doing quite a lot of public meetings and talking to people, and we do have posters, and there's a big part of future care which is about alternatives to emergency departments. But Dean, you're probably more cited on.
I mean, I think the winter, we have a winter kind of campaigns that focus it, and we do social media campaigns that are targeted as well. So we had one on vaccines earlier in the year, and as we get kind of outbreaks, then we were doing more on vaccines on there. But
yeah, I hear you, but I guess there's a bit of me thinking, you know, nationally they are looking much more, aren't they, at behavioural insights utilisation for things, and it's how, you know, what more can we do, or other things, probably a better way of saying it, in terms of behavioural science, in terms of how we help people to understand what choices they've got better. And so that's going to be a combination of
I think Sheila wanted to comment, and I'll come to you now.
I think the key thing really is about the reliability of the alternative as well. And if we can be really consistent and that those alternatives are always reliable, that's when you'll see behaviour change. Because if someone is told to go to pharmacy first, for example, and it's not open, even if they're told that 10 times afterwards, their decision will be made. So I think that reliability of the alternative. I think it's both hands.
Can I just tie this into the earlier conversation? Because in the previous sort of regime, campaigns may be run by ICBs or and I just wondered in the future design where there are behavioural programmes or redesign of, you know, campaigns of some description, where we probably need to consider where would that sit.
Do you want to comment on that?
Yeah, I mean, yes, we still have, because we will still be responsible for things like vaccination campaigns, etc. So it will still exist. It's just how we how we do those to the best effect, because if you're just repeating the same messaging, you know, if being a bit joined up about it, I think will really help.
Yeah.
To be honest with you, because if Somerset does a campaign saying, you know, don't come to our EDs, they're very busy, everybody may go to Dorset. If we can do that in a really kind of joined up way, I think that will be better, but campaigns would still sit.
I'm on a different thing. Don, were you coming in on that conversation? Or?
No, I was just going
If that's okay, Rob, sorry.
Yeah, of course, no, thank you. I need all the help I can get.
And we did lots of campaigns in COVID with actually sort of trusted voices. So it
Yeah,
wasn't necessarily the ICB, it was people in local communities that could talk about where experience that help. So I think there's something about how we engage with our communities at a broader level.
Good discussion.
Can I say a bit more on ambulance response times? Because when we talked about the assumption that this cluster will be the regional hub, kind of we've always, it's been read for a while, and it links to flow through the hospitals and kind of just, where are we?
So ambulances, so we'll come on to the plan in a moment, but this year we have kind of February has, oh no, March, we have seen them under 30 minutes, which is the target that they're aiming for across for CAP2 across the whole of the southwest. We've always had the best response times in Dorset, so we're at 26 minutes for that, and we have seen a big improvement in handovers. So we've never really had too much of a problem in Dorset for handovers, but there have been some hospitals across the southwest where there have been significant delays, and they have improved with the introduction of what's called the trusted handover protocol that's been put in place, which was triggered at 45 minutes at every emergency department across the region. And that's where there is a conversation that takes place with the ambulance trust and the hospital over, okay, it's now time to take the patient, what are we going to do it? And that's what led to some of the corridor care, though, because they've had to create the space for the people to be taken off the ambulance and put into the hospital.
So I don't think I'd understood that before. That red is reflective of the region.
It is,
not Dorset.
Yeah.
Okay.
That's in our role as
that's the commissioner, working as regional commissioner.
There's just something about the MI then, isn't there, given that we're the Dorset board, but we are the commissioner.
We are
I get both.
on behind, exactly, making that clear. Okay, thank you very much. We are on to the medium term plan. Alison, is that you?
Do you want me to start or do you want to? Okay. So we had an extraordinary board to consider this before we submitted, and we also went through our board assurance, but I thought it was important that we bring this back into our public part this morning, just in terms of what we submitted. So I'll just recap in terms of where we've got to. So the plan we've put in is to meet all our performance targets, with the exception of category 2 ambulance response times, which we'll just talk through, and community waiting times. And there's more work going on in terms of looking at what that's going to look like as we go into 26-27. Just to remind the board, as we go into 26-27, we've got a £2.1 billion budget in Dorset. And what we've set out in this plan, in conjunction with our partners, and that's really important to say, is a break-even plan. That doesn't mean it's not stretching, and we'll come back in terms of the things that underpin this as we go through the rest of today. Within there, if I just focus on the ICB a second, there is an ICB efficiency programme of 55.3 million, which is set out in the plan with some challenging targets. And looking forward, it's fairly similar to the 3 years of the plan. We've got a capital allocation of 20.3 million. Again, we've looked at how we're going to use that to support infrastructure, whether that's within the ICB, wider with the GPs, or minor grants in terms of GP services and voluntary sector. I wasn't going to go any further. I was just going to open that up to questions, but just in terms of looking at Adrian, we did do quite an in-depth conversation of this at the Finance Committee, where the Finance Committee was recommending it to be signed. So I just thought it was useful for us to all be aware.
Any questions or comments, please, Adrian?
Just an additional point, really, which is, again, just to share thanks and appreciation to everybody who collaborated to get to the plan. It's, whilst it ends up with the shortest discussion here because the problems have largely been solved before today, it's not trivial at all what people have signed up to. I think the additional point which we did discuss at Finance Committee, which is on the ICB but also on the providers, is the importance of having a month one start to execution of this plan, because we know that in 25-26 we're going to get there. A lot of blood, sweat and tears, but also some non-recurring items.
Yeah.
And the reality is there's nothing behind the clock for next year. So in terms of delivering the plan, efficiencies are going to have to start basically being enabled by actions in month one rather than month 6. So I think everyone's contracted for that, but just for visibility, that was an additional important point.
Yeah, no, really important. Thank you. I mean, as we move forward, we will want to protect resources for transformation and leftward shift. And therefore, this question of how does financial governance work in order that we deliver what we will say we'll deliver, and it doesn't lead to transformation and other resources being mopped up, is really important, isn't it? And I suppose my lesson from the last year has been for all three. It's not only for Dorset, but the rigour that goes into signing off a plan, and is it deliverable and will it happen, and then how we are forecasting it is really important, because we can't afford to have a late change in forecast, which suddenly means we haven't delivered recurrent savings and we're replacing them with one-off, because it leads to underlying problems of financial resilience. And so it was an interesting discussion with Region, really, Adrian and everybody, about how does financial governance assurance work next year in the context that we probably need more of it, and boards have got to be under even greater rigour that they will deliver whatever is in the plan, rather than that. And it's a really important point to raise for all of us.
I think strangely, I've enjoyed the conversations from the Finance Committee, because actually the sense is that whilst there will be no system control total on the go-forward basis, we succeed or fail together in the future in the same way as we have in the past. So actually the partnerships, relationships will continue to be just as important, even though the governance probably just needs to flex a little bit.
Yeah. I'm like a broken record. I'll just say it one more time. I'm sorry, everyone. If you deliver your savings before the year starts, if things go wrong during the year, you can take some mitigation action to deal with the new pressures. If you profile for savings to be delivered during the year, one, they might go wrong and it's too late to do anything about it. But secondly, you can't mitigate the pressures as they arise, because any action that you're taking is being used to cover the savings that haven't been made, rather than being able to mitigate the new pressures. And I love the NHS dearly. I think it's wonderful. But compared to other sectors, the profiling of savings to happen during or late in the year is really poor compared to practice elsewhere. Sorry, I know you've heard me say this so many times. You were very tolerant. Thank you. Forbes.
Yeah, thank you. It may be something Alison wants to cover in part 2, but it's just about where in the plan, and I may have missed it, is there an investment decision to facilitate the development of neighbourhood health? It's a question that's been raised nationally. It was raised with us when the national lead met us a couple of weeks ago. David is aware of that. And what is being suggested is between 1 and 2.5% is being invested in the development of neighbourhood health programmes. And I just wondered what the Dorset plan for doing that was.
Alison?
So in Part B, Forbes, we've got the detailed budgets and programmes going into next year. So we'll do the further detail behind this. And just a reminder to us as a board, when we had the previous conversation, we did talk about that. And then, we've been so fortunate in Dorset to get some external investment. So that's part of the conversation we've been having this morning about the business cases. But we need to address that as we go forward. And we need to do that across Dorset and the cluster.
So we'll talk about that in Part 2, if that's okay for us. Anything else, please, on that? Thank you very much. So then we move to items for decision today. We've discussed these in Part 2 meetings, but we thought it was important to bring the board and cluster board composition, as well as the terms of reference, to the public meeting. Obviously, this is as good a snapshot in time of where we are. I'm sure there will be iterations on this. Liz, is there anything you wanted to highlight to us at all?
If it's helpful, I'll give a really quick overview of the board composition paper, because I appreciate there's some sort of technicalities around the governance model that we're talking about bringing in. So yeah, we've already discussed this here and at Transition Committee, and we're bringing it back now with the feedback and the revised proposals for ICB board and cluster board, and also the governance. We're seeking the board approval on those three things. I think what's helpful to understand about the ICB individual boards is that we need to retain them because we'll retain our individual status as organisations throughout the year until we get into merger. And the proposal, though, is that those boards will only retain those items which absolutely cannot delegate down to a cluster board. The cluster board will be, in effect, a joint committee, but will become the key decision-making and assurance body for the cluster. So the only things we're looking at that the individual boards retaining will be around signing off of the annual report and accounts, signing off the operational plan and the budgets, and then we'll also have some governance items around delegations in terms of reference, which only the board has to retain for itself. There'll also be some decisions around merger, but we don't know what those will be yet or when they'll fall. So we've been asked about whether we can put a time on how many times that board will meet, and we don't know, but it will be limited, it will be single item, it will be approval items only, and there'll be no reporting or assurance coming through the individual boards. Hence why we've got that much more limited attendance, 6 execs, 7 NEMs including the chair, and representation from our 3 strategic partners, which aligns us with the requirements from NHS England and the minimum requirements from ICB constitution. The cluster board would be the main focus for our decision making, and that is the body that will meet on a bi-monthly basis and for a day as we meet now. And that's where we'll have the feeding in from the committees and all the sort of performance reporting that we have now, as well as decision making, and that will be delegated down from the board to the cluster board. We'll also be holding regular development sessions, and they will become cluster board development sessions. And that's where we have that expanded membership of the 6 execs, the 7 NEMs, the 6 partner local authority members, the 4 partners from the FTs across the cluster, our 3 primary care partners, representation as we have now through Forbes with the GP Alliance, 1 VCSE member as a member of the board. Sorry, lost my train as a member.
As a voting member.
As a voting member, which is sort of a step up from their status from the currently they are attendees with our board, and the 1 Health Watch participant, which retains their status currently on our board. The place non-execs and the place execs wouldn't be attendees on that board, but we'd ask them to come for development sessions to get that kind of holistic approach for development. Details in the paper, and I'm happy to go through technical points. But
I know we've done it loads of times already, but it's worth doing it every time. I'll say a little bit more in part 2 about merger and the NEM process. But for now, see any. Oh, thank you very much, Paula.
I just wanted to acknowledge the change for the VCSC membership of the cluster board, and to thank you for listening to the concerns that were raised and for taking those forward on our behalf. So thank you very much for that.
Well, thanks for raising it. Thanks very much indeed, Paula. Dan?
Thanks, Liz, and well done. That was really to kind of capture all those points. When I read it, the paper's really clear, I'm supportive of it. I just had a question about like host employer. So when someone's got a new role, it's their former ICB that's still a corporate entity, I know that's the wrong phrase, that employs them. And that board is the sovereign authority of the ICB, but everything which we can will delegate down to a cluster subcommittee that'll in effect act as the board.
Yes.
I just want to make sure I understand that. But it's that kind of that employer relationship and the duty of care stuff. But the employee will be one of the 3 ICBs, but then the delegation from those ICB boards down to the cluster will be maximised. Have I understood that?
The chief officers and the non-execs are jointly across the
joint-
cluster, so they're joint appointments.
By all three bodies. But they've not got 3 employers.
There'll be a technicality, I suppose, about how that's
There'll be a
where they're
link.
hosted and cross. But they are
Sort of
joint.
legacy.
I know I'm in the weeds, but I just kind of, I was thinking about the employment relationship.
Yeah.
Thank
and,
you.
And again, that changes dramatically at the point at which we go through a whole organisational change process.
Yeah,
But pragmatically, people will retain employment with their existing or one legal entity, because otherwise we're just having to two people.
The legal entity, I think, if you think rationally, is monitor still for some improvement. Where you know, it's a pretty common situation where the legality of whose one employer might be has sort of changed years ago through the arrangements of where it's being delegated and operated by. But you're right to ask the question to make sure we don't fall between the gap. I think monitor still exists legally.
I think they do. Yeah.
I think I wasn't just making that up. Okay, are we happy to approve that, please? And are we happy to approve the terms of reference?
Very well. Can I just go back? There was also the bit about the governance arrangements and the proposed committee structure, which is part of that, but I didn't want us to just step over it in case it's as set out in the paper.
Yeah, I think it's I think we've approved that.
Lovely.
Thank you for checking. No, are we happy to approve the terms of reference? Thank you. So we don't have any questions from the public today.
Oh, sorry, there was also the constitution changes as well that were part of that paper. They're just changes to reflect the new cluster exec structure, and there will be more to come following the board changes, but just for approval for the board today.
Yeah. Sorry, Liz, I'm terrible. I take all this approved in one go rather than read them out. Are we happy? For Liz.
My job.
It's your job, and you do it very well. Thank you very much. Any other business for today? Thank you. Well, look, key messages from the meeting. Thanks to all staff, and in particular, for this occasion, the board would like to thank Dorset ICB staff for their efforts, as well as board members and outgoing executives as well. And if we can place on record that as Dorset ICB morphs into its new future, the position is a strong one. Performance improvement has been good. Financial management has been good. And actually that sense of transformation and innovation, some very special things that happen in Dorset because of the strength of the partnership. If we can place all of that on record, I'd be grateful. Thank you to everybody for your efforts. We'll move into part 2 after lunch, and obviously the capturing the things that we most want to advise the cluster board or the place board are important things to remember in terms of corporate memory. We'll come to later on in the meeting. But for now, thank you very much. Can I ask for the item to be approved on the exclusion of the public for part 2? We'll have 35 minutes for lunch rather than half an hour. Thank you very much.